Thank you, and thanks for having me today. It's really very, very exciting to be here. So I guess we start with our polling question. So the question is, how many active cancer patients are on Flatiron Health's Oncology Cloud platform? So I think everyone enters that on and polling is closed. So we have the majority are C and D. Am I supposed to answer that question now? What the right answer is, or it'll come out in my talk. So great, thanks. So what's that?
There was a check mark on that.
Oh, there was. Sorry. We'll see if I got it right. So just to give you a little bit of background about myself, I'm a medical oncologist. I'm a community oncologist. I practiced in West Palm Beach, Florida for about 15 years. And I joined Flatiron Health in New York about a year and a half ago now, and I actually still see patients 1 day a week, most weeks in South Florida, and then spend the rest of my time in New York. And what I wanted to talk to you about in this session is to really focus on the use of big data and how we at Flatiron and others are using this to try to solve a number of problems, but specifically to focus on two issues today. And the first is the fact that, as I think everyone here knows, the majority of adult cancer patients never get onto clinical trials. So this is a number you've heard before, 4% or 3%, depending on who you ask, of adult cancer patients in this country enroll on clinical trials. And that's important because, one, clinical trials are a good thing. They're often good for patients. They're how we advance treatments. They're how we make discoveries. It's also important because what that means is that 96% of patients don't go on clinical trials. And for those patients, we actually lose an enormous amount of information. And the way I like to refer to it is we essentially lose the patient experience. The voice of the patient, what they went through, becomes lost. And when I left practice mostly to come to Flatiron and patients asked me what I was doing, to me to them, the theme of trying to learn from the experience of those patients who don't go on clinical trials really resonated very much. So we actually thought electronic health records were going to solve this problem, right? We thought that it would help us learn about patients who weren't on clinical trials, would make it more efficient for patients to get on clinical trials. And I think everyone here knows that hasn't actually been the case. And there are a long laundry list of reasons for that. But part of the reason that electronic health records haven't done what we thought they would do is really a data problem. And we talk about big data, but at Flatiron, we actually look at it a little bit different. This is one of my favorite slides. Than big data. We look at the cancer data problem as being one of complicated data. It's not big data in the way people do, data analytics on, like Facebook does or, Twitter does, but it's really trying to figure out how do you make sense of all of the complicated data that comes out of the care of a cancer patient. And there are a couple different components to complex data in cancer. And the first has to do with unstructured data. So you can think about things like demographic or a patient's age or a structured lab result in an electronic health record, which are obviously important. But a good deal of the information that is crucial for understanding what happens to populations and for understanding how an individual patient is being treated and what the right treatment is actually lives in unstructured data within an EHR. So this is an example of an EGFR test. For those of you who are clinical, you know that EGFR tests are extremely important in understanding how to treat patients with non-small cell lung cancer. But that information is typically buried in a pathology report or buried in a physician's note, not in a structured field. The other problem we get to is, in addition to that structured and unstructured data that sits in the middle of this slide, data in oncology is siloed. So data sits in multiple different places, data that's relevant, again, to the care of the individual patient, and again, relevant to the care of a population of patients. And how do you find those data and integrate those data with electronic health record data. So that could be mortality data, progression data, claims, genomics, and probably as or more important than any of these, patient-reported outcomes. How can we actually take the individual experience of the patient and incorporate that and link that into meaningful data? So there are lots of people, fortunately, who are in this area trying to solve this problem. And we're one of the groups that are trying to do it. Again, we're a company called Flatiron Health. We're in New York City, downtown in Soho. We probably have about 250 employees now. As my wife tells me, it's not that bad a midlife crisis to leave your practice and go work at a software company in New York. So that will remain to be proven, I think. But we are at our heart a technology company. And I think that's important because we really believe that this problem, this data problem in oncology, is a technology problem. But at the same time, in order to solve it, you need people who understand cancer and who understand data science. So we have a team of clinicians that includes, I think we now have 4 medical oncologists on staff at Flatiron, including myself. We have a team of nurses and nurse practitioners. We have quantitative scientists. We have medical informaticists. And the science part is really important because when you start to look at analyzing healthcare data and thinking about how that can apply to an individual patient or, again, a population of patients, it's really important that those data be accurate and that you not make mistakes. I mean, the stakes are actually quite high, here. So at Flatiron, we have software that we provide to providers, that we give to clinicians. And these are a couple of the software products that we have. The first is OncoEMR. OncoEMR is an electronic health record. It exists predominantly in community independent oncology practices. It's actually the largest cloud-based EHR. It's about 10 years old. It was acquired by Flatiron back in 2014 from the company that founded it called Altos Solutions. OncoAnalytics is an analytic platform that was developed by Flatiron that takes data agnostically from electronic health records, so from ours but also from others, and aggregates that with practice management data and other data in order to provide business and clinical intelligence back to individual practices. And the third is our NCCN outcomes database. About 8 months ago, we actually contracted with the NCCN to power their outcomes database, so a tool to allow the NCCN institutions to look at outcomes among their patient population and eventually to be able to do research on this. We're pretty widely spread across the US. This is a map of our sites that we have. It's not a cruise ship in the bottom. We like to joke that we have Puerto Rico locked up from an oncology software standpoint. But we have over 2,000 clinicians now that use our software and are approaching 1 million active patients. So greater than 750,000, that number was the accurate number. So really exciting to be able to have the opportunity to try to learn things from across our platform. So I want to go back to this original slide and again emphasize 2 real data problems that we're talking about here. The first, looking at all the areas around the center, integrating those data points into the electronic health record. But I want to really focus here for a second on that middle part and specifically the unstructured data. Because to us at Flatiron, this was really the toughest problem we faced in figuring out how to learn more from cancer patients. So I want to talk a little bit about the process that we're using to try to gain insights from unstructured data. And the term we use at Flatiron is technology-enabled abstraction. So think about the typical abstracting process that we have, and that's in the top panel here. So you have a chart and an individual abstractor who goes through the chart and pulls out a variety of information. So the patient's stage, their diagnosis, maybe histology from a pathology report. The problem with this is it's expensive, it's not always accurate, and it's a slow process. It's difficult to rapidly abstract patient charts. So we've developed a process, again, that we call technology-enabled abstraction. And the first point I would make is that we feel pretty strongly, and this is from our own personal experience, that using only machines, you cannot get data that is accurate enough to use in the real clinical world. So we know how to do natural language processing and OCR, but we don't believe you can actually solve this problem, at least not in 2016, and we actually don't foresee it being solved anytime in the near future without actually incorporating people into the process. So we've developed technology-enabled abstraction. What does that mean? So we take data from the EHR, the source data, we actually process that using computers and divide the documentations in the source data into different buckets. And those different pieces of information get provided to abstractors through software that we've developed that we call Patient Manager. So we actually have a team, I think it's of about 100 nurses, nurse practitioners, tumor registrars across the country, all of whom have different skill sets. So there will be people who are good at abstracting pathology reports. There will be people who understand progression, people who understand how to look at an imaging report. And they will collect data points and structure them. And what this allows us to do is first, using technology to make things go quicker, it allows us to check and double check, so we can look at agreement among abstractors, we can look at individual abstractors' accuracy, we can make sure that people are doing a good job, we can retrain people when they're not doing a good job, and we're able to really do this in a very, very rapid and a very, very accurate fashion. And the result from this is accurate data, and accurate data that is really relevant, again, to the individual care of the patient and for understanding a group of patients. So I'm going to give you an example here comparing structured data, that is data that you find in structured fields within EHRs, compared to technology abstracted data. So if you look at things like smoking status, histology, stage, or EGFR status, if you pull it just from structured data, the data is incomplete to varying degrees, but even at the best case stage, probably not complete enough to use in useful fashion. If you abstract the data and pull it out, you can get to almost complete data completeness with a high degree of accuracy. And what this allows us to do is it allows us to put together and to look at the entire patient experience. So we hear a lot about the longitudinal patient experience or the longitudinal patient journey. And it's about trying to figure out how do you put all the data points together so that in a structured and computerized way, you can look at a patient's experience over time using unstructured data from the EHR, structured data from the EHR, but also pulling together multiple external data sources. And I want to give you an example of how this happens for a hypothetical patient. And even though this is hypothetical, these are examples that we're using actually to look at real-life patient journeys now. So this is a hypothetical patient diagnosed with stage 2 lung cancer, has surgery, unfortunately develops metastatic disease, may get tested for certain mutations, go on treatment, ultimately relapse, and then unfortunately, which happens all too often, as we know with advanced lung cancer patients, dies of their cancer. So this is the story, and how do we collect all the data pieces to put that together? So you start with structured data. So demographics, the age, and in a lot of EHRs you can actually look at what type of intravenous chemotherapy a patient got, because that exists pretty well with structured data. And sometimes, even though it's a little hit or miss, you may know if or when a patient with cancer has died within an EHR. Then you layer on top of that unstructured data. So now you can start to look at things like what was the stage of the patient? When did they have their surgery? When did they relapse, and where did they relapse? Did they have a certain mutation that led to a particular treatment? Did they get rebiopsied at the time that they progressed? All things that are becoming increasingly more and more important as cancer treatments advance. And then we can start layering over external data sources. So if you look on the far right where it says date of death, and this always surprises people who don't live in oncology practices, is whether patients die isn't always recorded in EHR, and it's not always recorded when it happens when. And it's obviously a very important data point for understanding outcomes for patients. So being able to pull in external mortality data is extremely important. Derived data. So once you know the date of surgery and you know when someone developed metastatic disease, you can start to look at important benchmarks like recurrence rates or time to recurrence. And lastly, being able to lay on top of these claims data so you can start to look at costs of care and hospitalizations. So it's putting all these different data sources together, again, to understand the individual patient journey in a way that you can give feedback to that patient's clinician, and also so that you can look at populations of patients and start to think about doing things like benchmarking. And key to all this, again, goes back to the technology-enabled abstraction, and it's the ability to do this to scale. I don't need to go into all the numbers, but the point of this is we're able to gather information on lots of people in real time to enable us to analyze large groups of patients and to gain insights from that. So I want to segue a little bit and talk about how we're actually using the data, some of the ways that we're using the data. And we're going to start with understanding how patients are treated, again, at a global level, and then thinking about how we can understand that at the physician or the patient level in a way that we can give feedback to the clinician in a way that helps them understand how they're taking care of patients, and we hope ultimately to improve care. So think about a cohort of patients. This is a cohort of patients with metastatic melanoma, and you can look across the population and look at demographic information, what percentage are male versus female, what is the age at which patients were diagnosed, structured data. And then you can start to look at unstructured data to really understand important things about your population of patients. So how often are patients being tested for BRAF? BRAF is a mutation that's extremely important to test melanoma patients for. It's an important quality metric. Are they being tested? Are they positive or negative? That has great implications for how they're ultimately treated. What's the time between when they're tested or when they're diagnosed and when they're tested? It's important to test people early on. It's an important quality metric. What kind of insights can we get into patterns of care by looking at these kinds of things? And then we can start to think about how patients get treated over time, looking at different treatments. So this is a 2-year period going from July of 2013 to July of 2015, looking at different therapy classes over time. And if you look on the right side, as you can see this new therapy emerging, those are actually the PD-1 inhibitors that were approved in 2014 for treatment of melanoma. So you can see appropriate uptake of those patients. But then you can dig deeper and say, well, it's really important for me to understand what this population looks like based on whether they have a mutation or not, or based on what line of therapy they're receiving, in what part of the treatment sequence they're being treated. So we can layer over and say, let's look at first-line patients and patients who have a BRAF mutation, and let's see if in that population of patients the treatment is appropriate. And what you see here is the use of those immune targeting agents is actually much lower here, which would be considered appropriate in that scenario. And then we can again start to look at the individual patient or the individual clinician or the individual practice level to take important metrics and give information back to practices in a way that doesn't involve them to pay someone to go abstract charts, that doesn't create a burden on them, but that allows them to get insight into how they're taking care of patients and hopefully make improvement on that. So this is a slide looking at use of antiemetic therapy in patients based on how likely the chemotherapy they're receiving is to cause nausea and vomiting. And you can look across this at a practice level. You can also look across things at a physician level. So an important quality metric looking at how often chemotherapy is given either in the last 30 days of life or the last 14 days of life. So these are data that we're providing back to clinicians, again, to help them improve care, and providing these data back to them in a way that doesn't create an increased burden on their practice operations. And it also allows practices to benchmark against other practices, against other groups, against national averages. So KRAS testing. So looking for KRAS mutations is something that's important to do in patients with metastatic colon cancer. It's recommended by the NCCN. It's considered standard of care. So we looked across a group of practices at how often KRAS testing was done and allowing patients to compare themselves to other practices. This also, though, makes the point of what I said earlier about how important the science is when looking at healthcare data, whether it's healthcare data that's impacting a provider or a patient or healthcare policy. And that is, the risks are high. You need to do this right. So this KRAS story was really interesting because when we first looked at the data, we saw that KRAS testing was actually lower than we thought. We actually thought we had a quality problem across practices. But when you look into the data and you dig a little bit deeper, what you find is that a lot lot of this had to do with timing. So physicians were actually testing patients for KRAS, but not always immediately, so that as you go further in time and get more recently diagnosed patients, you get a larger population who hadn't been tested. So at first glance, a quality problem. When you dig into it and have statisticians who are able to help you, you actually find that what you're actually seeing reflects appropriate care. So I want to switch and talk a little bit about patient outcomes. So what we were really looking at there is process, or how patients are treatment, what they're receiving. Outcomes is so important in oncology. It's, I think, one of the things that has been really difficult to get information about, especially in real-world patient situations. And it's, of all the slides I'm showing you here, it's the one that I think we're most excited about at Flatiron. And I think that being able to do this and, across different groups is going to be extremely important. And a lot of this came out of the work that we've been doing with the NCCN. And I'm going to just show you one slide about this, which I think kind of encapsulates all the information. So this is a slide of real-world cancer patients treated in community and academic practices, and it's looking at the overall survival of patients with non-small cell lung cancer. And there are a lot of really interesting points to make about this slide. The first is that, and again, for those of you who aren't clinical, lung cancer is two diseases. It's non-small cell lung cancer and small cell lung cancer. And there is no way, based on structured data in an EHR, to adequately distinguish between those two groups. So this is utilizing that unstructured data processing that I talked about to actually pull out a cohort or a population of just patients with non-small cell lung cancer. So using unstructured data processing. We've also divided the patients by smoking status or not smoking status, which you also need to be able to do. And then these are survival curves. This is what's called a Kaplan-Meier survival curve. So as you go further out on the x-axis in years and get lower on the y-axis, it's patients dying from their cancer. And you can't generate a survival curve, survival being probably the most important outcome that we look at in cancer. You can't generate a survival curve without understanding when and if patients die of their cancer. So this is based on external mortality data that was pulled in and anonymously linked with a de-identified patient population to produce this graph. So again, we think that there's a real opportunity to learn by being able to look at true outcomes, and we've actually piloted delivering this information back to an individual practice. So an individual practice can say, what is our lung cancer survival rates? How do they compare internally? And how do we look compared to other institutions, other practices, other regions of the country? And then lastly, matching patients to clinical trials. And I'm running a little bit low on time. So there are a number of reasons that clinical trial accrual is low in this country for adult cancer patients. Some of it has to do with trial design. For example, a clinical trial is designed with a control arm that doesn't really reflect real-life patterns of care. Sometimes a clinical trial is designed and then opened at a site where the site doesn't have the right patients to accrue. So we're spending a lot of time working to try to figure out ways to help with clinical trial design as well as with site identification. The third part where we see there's a real opportunity to increase clinical trial accrual is within oncology practices, specifically community practices. The process by which patients, before they enroll on a trial, are screened by physicians and staff within the offices is terribly inefficient, and there actually aren't good software tools to help practices do that. So what we've done is we've actually created software, which we're now piloting in 5 sites, to help with that pre-screening process, to help the clinicians and staff within an oncology practice identify patients who may be eligible for clinical trials right now, who are potentially eligible at that given site, but ultimately to look for clinical trials at any site, and leveraging the ability to process unstructured data and to find out those important data elements and to use that to try to present to clinicians and present to research coordinators in the offices those patients who may be eligible for clinical trials. And so I want to go back to, to conclude to this slide, 4% of patients enroll on clinical trials. We need to increase that number. realizing that we're never going to be in an era where all patients go on what we consider now as kind of standard prospective clinical trials. So at the same time, and probably most importantly, trying to learn from the remainder of those patients and take that information, provide it back to the clinician, provide it back to the researchers so we can learn and hopefully improve care for all patients. So thank you very much.